Thank you so much. My name is Kirby Smith. I am an advanced certified pharmacy technician and community health worker with the University of Missouri Specialty Pharmacy. I am also with our adult and pediatric cystic fibrosis teams, serving as their pharmacy technician. And so today I'll be presenting on clinical advocate, which is our evolution of the patient medication liaison within a health system. So our approach to advocacy within our health system and how we're able to serve our patients. So our description of a patient medication liaison, we are personal liaisons that have direct access to providers, nurses, pharmacists, and healthcare team members. We are assigned individually to different disease states and able to take care of our patients directly, to have that one-on-one access and that unique care for them. So we are at a minimum a certified pharmacy technician. We are paired with clinical pharmacists, and our responsibilities, we take care of prior authorizations, appeals, communicate coverage determinations with providers, and help our patients with barriers to access to their medications. So we're working from the pharmacy aspect of everything, and taking that approach to help our patients by also working in that clinical setting. When we first started our program, we were directly in the physician's offices, working one-on-one with them directly. As COVID has come around since 2020, we've become a little bit more remote. Most of our patients work from a remote setting. I do still, however, go into the clinic, and I'm in the clinic every day so that I can see my providers, so I'm there for my patients in that aspect. But we also are able to coordinate monthly refills for our patients that do fill with our specialty pharmacy. So how are we essential to patient care? We provide our patients with one direct, dedicated person for their medications. So I know a lot of times in other pharmacy settings, especially with larger retail pharmacy settings, if you're calling in on a mail order line, you're talking to somebody different every month who may not necessarily know the ins and outs and the nuances that go with your billing for your prescriptions or getting access to your prescriptions. So we're there, and we have that one person that knows. I know with my patients in particular, they sometimes have tertiary billing that comes along with processing their prescriptions. And so because I know that that's there, I don't miss it. Whereas sometimes at other locations, they may not be as familiar, and sometimes those automatic billing procedures are not in place. So those billing can be missed and end up with those large copays that they aren't expecting because simply that step wasn't taken. We also know our patients and can anticipate their needs. We deal with them every month. We talk to them. We know what's going on in their lives. We are able to anticipate and make adjustments. They come to me all the time that they're going to have an insurance change coming up, that they're moving this, that, and the other. So I can pre-plan and make that adjustment to make sure that I'm meeting their needs. We're very knowledgeable in available resources, coming to conferences like this and other things like that. We know what charitable assistance programs are available for our patients, what copay cards are available for our patients, and other resources. Mentioned earlier, we communicate directly with the providers. Like I said, I'm right there in the office. If I need something, I can just go tap them on the shoulder and say, hey, doc, I need this. And because we are so closely integrated with the providers and everything, we're able to provide those rapid responses to patients regarding their prior authorizations for their medications. The University of Missouri Health System has 7 hospitals that we serve with over 50 clinics. Our Mizzou pharmacies, we currently have 12 outpatient locations, including 2 accredited specialty pharmacies, and we're able to provide free prescription delivery to anywhere in the state. We also recently just got our license where we can also just ship to our patients that are living in Kansas, because we do have a few folks that live in the Kansas City area just across the state line, so we're able to send to them now as well. So. Mizzou Specialty Pharmacy launched in November of 2015. We started out pretty small with only 5 patient medication liaisons, which is what I am. We served 8 specialties, so we had neurology, cystic fibrosis, pulmonology, non-CDF, pediatrics, nephrology and post-kidney transplant, oncology, and I'm trying to remember what the other ones were. Dermatology was another one. And we had 1 clinical pharmacist. We were 1 specialty location, and it was maybe a fourth the size of this room that we worked out of. And started with only 165 patients. So, but in that initial first full year of having our specialty pharmacy going, we were able to reduce the turnaround time on specialty medications to 24 hours. Our PMLs were able to get 82% first-time approval rates, and new starts were able to have medication in hand that included shipping time if we needed to ship to them, initial counseling, and education on a patient and on administration, especially for injectables. So they were able to have that medication in hand and all that information provided to them within 5 days. And the average savings on a prescription in our first year was $180 per prescription, which increased adherence rates for all of our patients. So. Brief timeline, like I said, we launched in November of 2015. We're on our 8th full year now. So we've had our URAC accreditation, we have our ACHC accreditation. We also now have 2 locations, and our original location is dedicated directly to our oncology patients, as is located directly in our Ellis Fischel Cancer Center. So it's right there for our patients as they're leaving from their appointments, they can get their prescriptions. We now have over 3,000 patients that fill with our specialty pharmacy on a monthly basis. So we've continued to grow across the years. And we like to think of it as a multidisciplinary approach. So, like I said, we're all in the clinic right there. I am part of the CF team. I work with the doctor, the clinical pharmacist, our respiratory therapist, our nurse, our dietitian. The whole team is right there. We're all in one. We're not a separate entity from the provider's office necessarily. Sometimes it's very convenient too when we're calling in for prior authorizations and whatnot, because we're kind of dual-hatted. Yes, I am technically a pharmacy technician and I am employed by the pharmacy. However, I am able to call in prior authorizations on behalf of either entity. If it's a cost exceeds on a prescription, I can be the pharmacy. If it's something clinical related, I can provide that information on behalf of the provider's office as well. And then our clinical pharmacists are very involved in our patient care as well. Many of them have at least one additional board certification, and we do have pharmacists available 24/7, 365. We have an on-call phone that patients can call at any time, if it's after hours, holidays, weekends, you name it. If they're having some sort of adverse drug event or have something going on that they just can't wait until the next business day, they can get a hold of a clinical pharmacist to get their question answered. 95% of our patients are enrolled in our clinical pharmacist program, and the 5% that are not are strictly out of the patient's choice. We offer it to every single one of our patients, and we just have a few that have opted out of those services. So you can see here, most of their interventions have to do with care coordination and medication monitoring. However, they do get involved somewhat in the financial aspects as well as other social determinants of health as well. So this is how our pharmacy compares to other nationally accredited, URAC accredited pharmacies. So where other pharmacies, if they get a new prescription, they are typically getting it out the door over a week. We're able to get it in under 2 days. Same thing if they're needing an intervention, it's taking, a week and a half to 2 weeks sometimes, and we're still under that 2-day mark where we're getting those prescriptions out the door for our patients if they're needing those interventions. And intervention can be anything from a prior authorization to counseling. Any number of things can be that intervention that they're needing. And we've taken our approach beyond specialty. So specialty is a big portion of what we've done, but we also have other PMLs within our health system that we have taken to make it really a whole health system approach to advocacy. So we have our prior authorization PMLs. We currently have 13 of those within our health system. They serve all of our outpatient clinics, and they take care of prior authorizations and appeals for any non-specialty medications. So if you are being prescribed Brio and your insurance requires a prior authorization, it's a non-specialty med, they are there to take that and get that prior authorization resolved for you. Then we have our med adherence PMLs. We currently have 8 of those within our health system, and they are there to monitor the CMS and MTM processes and help patients with those adherence and refill activities for those prescriptions. So they'll do the regular refill calls and setting those up for the patients to get those. We also have transition specialists. These are for our patients that are discharging from a from a hospitalization, and they're being started on a new medication or a new series of medications. And so they are there. They are on the floor with the doctors during the hospitalization, and as the discussion is coming up on when they're getting ready to discharge, if they're starting on something new, they are involved with that doctor right there on the floor, getting those prescriptions sent to the outpatient pharmacy so that they can take the process, get the prior authorization in there if it's needed, investigate for any copay assistance that's needed, and then make sure that that patient has that medication in hand before they're walking out the door. On average, it takes them a little over 2 hours from the time that the doctor sends the order to the pharmacy, and they're able to have it delivered bedside as they are discharging. And then we have our infusion PMLs, which focus on our pre-certification of infusion medications for our patients that are in our ambulatory infusion units. And they have an astounding 96% approval rate for their infusion meds. So since 2015, when we got started, we have now gotten to where we have access to over 250 specialty medications for our patients, including several limited distribution medications. Like I said, I work with CF, so we have access to all of the cystic fibrosis modulators that are limited distribution. We have a 96% approval rate on prior authorizations. And in 2023, last year, we saved our patients $5.6 million on prescription medications alone. And that's only counting specialty medications. We're not looking at any of the other medications dispensed by our pharmacies. We now have 11 specialty PMLs, and we cover 13 specialties throughout our health systems, and we have 9 clinical pharmacists. We also now have our own drivers that deliver statewide and run certain routes. And like I said, we are duly accredited with URAC and ACHC. And all of that with our outcomes last year, we maintained a 97% Hep C cure rate for our patients, a 93 on our Net Promoter Score, and our HIV patients were able to maintain a 92% viral load suppression. And we dispensed over 15,000 specialty medications per individual fills last year. And the reason that this is also important is because it comes down to patient success and outcomes and the access that they have to care. And it's really important to us that it starts at the source. We are right there. We are getting access to the patient and making sure that they're getting access to the medications as soon as it's sent out the door. We currently have 53% of all specialty medications prescribed by a university physician are sent to our specialty pharmacy. And the other ones, obviously, we can't collect them all because we're not contracted with all the pharmacy plans and benefits, but 53% of our providers send a prescription to us. And usually, even if it's a first time being dispensed, they'll send it to us so that we can do that benefit investigation do that prior authorization, and then if we determine that we're unable to dispense for the patient, we send it to the appropriate pharmacy, whether it's Secreto or CVS or Carelon or any number of other places that it might have to go to. And we've been able to determine that because of this, the closer we are to the source of the medication and where it starts, the faster we can be intervening and giving success to our patients. And it comes down to a whole system. It can't be done by just one part of the system, because otherwise the other parts don't come through. So collaborating together with our physicians and our patients ensure that they get everything that they need and that they have access that they need to all their medications. And that is all I have. And I'll open it up to questions.
Thanks. It sounds like you guys have a great service. Can patients contact you directly for services, or do they have to have a referral through a physician for your services?
They can contact us directly. Usually it's through their physician that they're contacting us, though, is because their physician has prescribed a specialty medication. But I mean, my patients all have my card, even if they're not filling a specialty medication. Every CF patient that comes in gets my card. And so even if they're not filling at our pharmacy, they can still call me if they're having issues with copays or anything else. I'll still help them to get enrolled in whatever they need to get the assistance they need.
How would you, or like, what would you attribute the 96% approval rating to? That's incredible.
I don't know if anyone was in the class or the session previously with triage cancer. It really comes down to knowing the methods that there are out there. That, like, I get countless times I will get patients that will call me or message me and say, hey, I got this letter from my insurance that says that this is not going to be covered anymore. And knowing what that actually means to say, well, yeah, they're telling you that it's not covered anymore, but for us, what that means is that we need to do a prior authorization. And if that prior authorization is initially denied, then we need to do that appeal. And because we are all focused on one single disease state, well, or group of diseases like rheumatology or something like that, we are familiar with what criteria the insurance is going to be looking for with those PAs. We know that they're looking for, like I'll use my patients for example, with CF, like I know when they're starting on it, they want their genetics, they want their PFTs, they want their LFTs. Like I know exactly what insurance is looking for, so I know exactly what to provide them. To ensure that we can justify that medical necessity.
How about now? Oh, there we
There
go.
we go.
With the specialization in certain disease states, do you see a difference in the amount and type of work within each disease state? And if so, how do you address that from an equity and fairness perspective in balancing workloads?
So I can definitely say that there is a way to see that there is a difference, because you have, for example, myself, I work with cystic fibrosis. I manage 140 patients that I directly manage all their prescription refills for. However, my counterparts in, say, rheumatology, they may have 300 patients that they're managing. And while the patient numbers vary because of that, when you compare cystic fibrosis with rheumatology, my CF patients have like 10 prescriptions to 1 for rheumatology patient. So while the patient numbers may vary, the prescription numbers end up balancing out pretty evenly.
What other questions? We have to use the microphone.
I just wanted to ask, do you guys do patient assistance for all your patients, like the copay cards, the grants,
Yes.
the free drug?
Yep.
Okay, I just
We
wanted to clarify on
We
that.
do all of that, copay card enrollment, patient assistance enrollment, grant enrollment. We investigate all of that for them.
Okay, and for oral and infusion?
I believe that infusion does that. So like I'm on the outpatient side of things, so I don't get a whole lot into the infusion and that aspect of it as far as that care goes. But I do know that for all like, as if it's going through a pharmacy benefit, we're getting access to assistance for them if it's going through a pharmacy benefit.
I'm going to take you and then you in the back.
I will also know I made a typo. My cell phone number is incorrect on this slide.
So I have a quick question for you. I don't know if this is the appropriate forum or not, but I'm just wondering what strategies you guys have been able to deploy in copay card accumulator situations.
We have not encountered too many issues with accumulators for our patients. We see more maximizers on our end. And so with the maximizers, we've found that proper billing sequence to make sure that their benefits are getting used appropriately is the biggest thing for us when it comes to the maximizers. But I honestly, with my patients, I haven't seen too many accumulators.
How do you get referrals? Are they sent to you through Epic, or are you getting calls, or?
So
Something like
the
that.
way we do our referral process from our prescribers is they send a prescription. Every single prescription that gets sent to our pharmacy, if it is a specialty medication, we count that as the referral and we start the process of reaching out to our patients and getting them taken care of. So we have a very open dialogue with our providers. We are a teaching hospital, so we get new residents every year, and we will go and meet with the new residents and say, hey, I'm your PML, this is what my role is. I'm here for if you need me. And, you know, the easiest way for me to get involved is for you to send a prescription to the pharmacy, and then I can take it and run with it. I can do a benefits investigation for the patient. I can take care of the prior authorization and then triage the prescription from there to the appropriate pharmacy for the patient.
Are any of your locations 340B?
Yes.
We probably have time for one more question.
Hello. I'm just wondering, over the years, what's been like the most impactful change to the role of the PMLs that you've implemented?
I feel like it's ever growing, honestly, and gosh, impact. I have to think on that. Honestly, like as far as impacting the role itself, because I feel like even though we've been doing it for 8 years now, like we're still growing and learning every step of the way. I think the process of going through accreditation has been really impactful for us, just to go through that process and know what it means to be an accredited specialty pharmacy.
Okay.
Currently, yes. It is limited to Missouri. It is only it's only available to patients that are filling with a Mizzou Specialty Pharmacy or see a University of Missouri provider.
I think that's all
All
we
right.
have time for.
All right, thank you so much.